Welcome to Adoption Roundtable, a place to encounter the latest adoption research, policy, and practice in an accessible way. This is a space for adoptees, adoptive families, birth families, and adoption professionals. I'm Dr. Emily Helder, a clinical psychologist, researcher, and professor at Calvin University. I am also the co-editor of the Rutledge Handbook of Adoption, along with Dr. Alicia Marr and Dr. Gretchen Robel. In Season 1 of Adoption Roundtable, we'll be having conversations with the authors of chapters in the Handbook of Adoption. They are top international scholars in a diversity of fields, and together we'll talk about their work and what it means for understanding adoption. Hi, welcome. I'm Dr. Emily Helder, and I'm here with Dr. Maria Kroupina. She's a pediatric psychologist with the Adoption Medicine Clinic at the University of Minnesota, and she's also the director of the Birth to 3 Clinic and the Early Child Mental Health Program. Her academic work focuses on the development of children who have experienced early adversity or toxic stress and identifying those children early, getting them intervention to try to prevent negative long-term outcomes. And she's also the co-author of a chapter in the Handbook of Adoption entitled Adoptees with Disabilities and Medical Concerns. So welcome. Thanks so much for being here. So I'd like to start by asking you a bit about your role at the Adoption Medicine Clinic. Can you tell me how you came to be in that role and what kinds of things you enjoy about your work?
I do have a very long relationship with clinic, and myself, as you hear from my accent, when I joke that I'm from Minnesota, people don't trust me because you can hear right away that my accent is can let you know that I'm from Eastern Europe. I'm from Moscow myself. I did clinical degree in clinical psychology, which is equals about the master's in child clinical psychology in Moscow. And then I came to do my PhD at the Institute of Child Development, which is one of the best, or I think still considered the best program in graded program child psychology in the United States. I came to do my PhD, and I think it was my second year when I started child development. That Dr. Dana Johnson, and it would be like 96, 97, something, when he came to talk about, children that they start to see in the clinic, that before when they were seeing the little infants from Korea and India, they didn't know how to help them as a medical team. But when they started to see Eastern European children, they had so many questions about development, and the children are older and they didn't know how to help them. It started to research, that institute became engaged in the research. And I, as a graduate student, probably we did run the first research participant from one of the Eastern European countries at that time. Then that became a wave of research funded by NIH done in Minnesota, in the United States and Romania. And I think it changed the conceptually how we see early mental health, how we see early adversity, risk factors, how we're developing not only our next research questions, but also how we're developing clinical programs. That's why I was able and was lucky to be with the program starting really at the beginning when, like people asking, what about mental health? We have medical doctors, we have OT, we have PT. What mental health? Correctly, that's where we were, and now we see how much we need each of these areas and how we need to work together to emphasize the complexity of the issues these children have. That's why in the history I did go from graduate student to doing research, to do clinical work, to do right now I'm very proud and involved with work that our clinic is doing with foster care children, and we also develop, based on what we learn about early development, we develop our own program, Birth to 3, that also designed for other high-risk groups of young children.
Yeah, and I wanted to ask you a little bit about that Birth to Three clinic. Could you say a bit more about what kinds of services are offered there, what that looks like?
We do have, this clinic is designed for the children birth to three who experience multiple risk factors. And it's again, the first group is, we're talking now, we started with children adopted from institutional care. Now we see in foster care children, but it's also a big group of children who exposed to stress due to medical conditions, due to like NICU babies, children with heart transplant, other complex medical conditions who go for hospitalizations, possible stress related to pain, maybe isolation from parents due to different risk factors. That's kind of the groups that experience really high level of stress. But we do work, of course, with primary pediatrics clinics and sleep problems, the problems related to parental stress. That's we also engage. But the idea of this program to help to integrate understanding of early mental health, early brain development into pediatric practice, from specialty clinic like adoption clinic to primary care. And also we do have outpatient clinic that we see in the children, we provide intervention, and now we're starting to do more and more inpatient work when we can see babies when they are still in the hospital with their parents. It's kind of the scope of the work we are doing.
Wow, that sounds like a really unique opportunity, interdisciplinary and really targeting a wide range of ages for kids. That's really exciting.
And I want to stress, I think we would never be there if it not will be the work with adoption medicine program. Historically, I think it's important to recognize this program is pioneering so many ideas from research to clinic that then they become a part of our work, but then we also can translate to other population. It's been historically a program that very on top on doing research, learning from research, and moving forward with the most innovative ideas.
Mm-hmm. Yeah, and that's actually why we were so excited to have your team participate in the handbook, because I think there's lots of people around the world that recognize your clinic and the innovative approach. Yeah, I wanted to ask you a bit about the chapter. So the beginning of the chapter starts with a history, a background of adoption with a special focus on the adoption of children with disabilities or with medical concerns. You alluded to this a little bit in what you said earlier about when Dr. Johnson approached you, how things were changing in terms of what kinds of kids were coming. But I'd love for you to say a little bit more about how you've seen the trends in adoption changing in your clinical work, in the kinds of kids that you're seeing, in the kinds of things that you need to address.
As I said, initially it was more like a babies coming, but then we have a big trend of children from institutional care.
Mm-hmm.
In European China, there would be the major countries when we saw children coming, and initially that we all thought that that's quite a unique group, we will not be able to learn from this group. And that's where kind of we became to face it, how much similarities between what we see in this group to the children that we here seeing traveling from one foster care family to another, seeing abuse, neglect, that we conceptually can really learn from children from institutional care. And you ask about the trends, it's definitely unfortunate, sad trend that we don't see these adoptions for multiple reasons. And we all hope that would be reasons that this family, more families adopt their children domestically. It's unfortunately not completely the case, and many it's very related to political issue. And like with Russia, I was myself participating in raising voice of the children, but we all understand it's more to that then the will of the parents open their hearts and ask professionals to help them. Right now, we definitely see less of children coming from institutional care internationally adopted, but we see more children adopted from foster care domestically, which is wonderful, wonderful. And how many children need help? And I do feel like we're better prepared. We have more resources. It's far enough, or not enough, from what we need to give to these families and to these children. And I always, tell parents when we talk to them that, parents feel guilty when they cannot help a complex child, particularly if it's a mental health needs. And I do feel like as a society, we need to raise voice, and I hope this chapter and more we talk about this will help to the society will understand if we place a child with medical condition, like for example, a child with cardiac problems, we always train parents. We help them to understand them. We give them specialists. We're not as good about mental health and neurodevelopment, understanding of neglect, abuse, prenatal exposures. We need to be outspoken about this, and we need to be proactive in helping parents. The parents would not feel overwhelmed, and they will feel prepared and ready. We all strongly believe that that will change the world. And what we, over the years, we saw in terms of the best intervention for any child is the family. The best intervention for the family is preparation and preventive care, not catching up when we see this family already coming to us with enormous need when a child like years in the family. No, we need to prepare, and we need to understand these children need a longitudinal clinical follow-up that allow us to assess and give help at different point of development. It's not about one time, it's about being available for parents to know where the resources. And I would say I find it's the most rewarding when we hear from parents say, when something happens, they say, oh good, we know who we can email, and you ask the question, find resources. We're not yet there where we want to be, but I would say in the years that I'm again I'm trying to remember what it was, the 96 and 97 when I first time was in the clinic as a grade 8 student. We're far from this place. We're far, but we're still learning. And I do think we need to be outspoken as much as possible. And I do hope that we will be able to continue to do as much as possible training. So we need to train professionals out there who can do this work and who can create the centers like our center to prepare families and provide support for them through the years as they're helping their child. Because brain is a mystery we all learn every day, and by supporting the child and supporting the parents, we can reach the points that we never believed at the beginning. And we do have so many wonderful stories to share.
Mm-hmm. Yeah. It seems that your model, if it could be replicated, it would really help reduce some of the adoption disruption, adoption disillusion, some of that model of giving that prevention and education at the front end and helping early before problems get more intense, can help keep kids more stable in families.
Yeah, that's what we hope, that's what we're working for. That's why we collect data. We're trying to think and analyze always what our work, because that's an idea to develop a model. And for me, that's what we are moving toward, servicing more children, not only domestically adopted, but in foster care, and working, like with biological parents, with foster families. That's a unique opportunity to give more services for these children, to see less disruption, and better outcomes.
Yeah, yeah. When you, one of the things that I read in the chapter as we were working on it was about the assessment that's done of children and of families early on, you know, shortly after the adoption placement and in the assessments afterwards. And one of the things that was discussed in the chapter was about buffering relationships for kids who've experienced early stress. And I wonder if you could say a bit more about what that looks like what kinds of behaviors are you looking for parents to be doing, and why is that so important?
It's important to understand that any human infant born with need to be taken care of, and any uh, res- response to child behavior, like child's crying and responding to parents, that's a buffering, correct? It's not a magic thing. It's what parents do very intuitively every day. And this in optimal relationship, it develops really slowly as a building over the first years of life, starting the first day. And it's by learning this, understanding your child, hearing your child, seeing the need, and responding to the need. And then slowly moving also a child to learn that sometimes child can hold on the needs, and it's safe and it's okay to be frustrated. Everybody knows crying little one who is sitting on the floor wants extra cookie. But it's also buffering if mom or dad saying, "You okay? You okay? You're just upset because you want a cookie, but unfortunately it's not possible." That's a buffering because a parent getting a very kind, supportive relationship with child to learn frustration. And that's all these moments that they building healthy brains.
Mm-hmm.
And we know that any experience, almost any experience, and I still remember, like I saw children from Haiti earthquake. One child was experienced it with parents, and another child was from institutional care who was dropped on the street and was just lost. At two, both kids were in effect so different, correct? Like because if you're with parent can protect, understand, see the need. If a child is doing this on their own, that's when we're talking about toxic, when we are talking about too much and overwhelm. Of course, the most devastating for child when protective relationship becomes, not protective by abusing or neglect. That's what we see is very complex. And that's unfortunately what the problem is, to get these kids who experience toxic stress or the relationship that instead of buffering, hurting a child, emotionally, physically, ignoring child, these children develop coping skills. They cope with this. They need to deal with that somehow. And to take care and buffer these children when they come to their family is much more complex, much more complex. And now we always tell parents, we always each of them come with a book, correct? That you read and you start to kind of know what to do. Unfortunately, that doesn't work like this. Stress, trauma, the adversity changes in some in unique ways. Sometimes we see twins and they completely, parents need to learn, and that's why we need professional help. Again, we need professional help with young mother who single, depressed, and have a harder time to read a child's signals, correct? And
Mm-hmm.
buffering, we need help there, or we need help when children who had the experience of no buffering relation don't know how to signal, how to ask for help. We need help parents to walk these roads. Um, Strategies are much more complex. If it first it's important for just say like how we do this, this, and this. I would say first of all, as we need important to recognize the parents to hear and get consultation with the complex kids when we talk about the children with multiple needs.
Yeah, one of the things that I chatted a bit about with Judith Eckerly and with Megan Bresnahan when I chatted with them was that they really appreciated the interdisciplinary nature of the clinic because you could each kind of contribute toward decisions related to behaviors that families are asking about, and so what you've been describing are behaviors that might be driven by early attachment relationships that are disrupted, missing, marked by abuse. And Judith talked a bit about medical conditions speaking into that. Megan talked about sensory issues. So I'm wondering, in the interdisciplinary nature of things, what are you looking for when you're assessing families to say, hey, I think this is related to an attachment piece and this behavior that they're asking about versus a sensory issue? What are some clues for you as you're meeting with families?
Yeah, I do think first it's a critical have an approach. I feel it's kind of like we really need particular for any child who hasn't gone through this multidiscipline assessment. We need to be sure that at least somehow they see medical providers if they see only mental health. And this is a very we do see initially, with young kids, it's parents more go to with pediatrician, and a little bit older kids go, school age kids go to only mental health. None of this is a balanced approach. I think we have to have both. I do feel like to understand mental health, we need to understand genetic syndromes, we need to understand prenatal exposure. And it's very important, I would say, and also everything related to immediate health needs with a child. That's critical step that needs to be done. We totally trust Dr. Eckley and our medical team amazing on getting the really broad scope on what it can be underlying this, because that's almost like the first and central step. To answer your question about sensory and relationship or based on the difficulties with developing relationship. This is a complex question that you don't always know the answer unless you walk the road. And in multiple cases that we see over the years, it's a combination. And for parents to understand both is really important. I would say that would be a starting point, and we learn again, health is first. We just need to be sure that the child doesn't have. Then the next step, I would say, combining mental health approach with sensory if needed. That would be the next major step to kind of help child to be more regulated and more regulated within a new relationship. Does it make sense? And that's why that's the most effective combination of intervention for many, many children, because if you experience this early adversity, sensory issues and emotional regulation, they all kind of, like a trace. It's really hard. It's just, I would say it's just to some degree, it's one big part of brain, correct, that we are affecting with different and very targeted methods that are very complementary. Mm-hmm. That's how we do see it for this approach, and that has to be the first what we for children who need it. But I will tell you, out of like we just did analysis. I think it was 90 kids. It's almost unless it's really a little baby, and sometimes they say, okay, we need either consultation or we do need OT mental health for sure if a child spends sometimes. It's just such a disruptive for a child not to have stable relationships that I think for most of the kids who we see in the clinic, it's needed. But I do feel like I don't think we have enough to tease it apart, but we are very good and working together and figuring out how to combine these approaches.
Mm-hmm. Yeah, no, I would think the model of the clinic allows that integration really nicely. Yeah, to follow up on that a bit, are there specific intervention approaches or intervention models that you have found really helpful in your work?
I think the younger age we have a really great models. I do have the two major model. One preventive relationship model. It's ABC, attachment behavior by catch-up intervention, developed by Dr. Mary Dozier. 10 sessions preventive intervention for children just placed. That's a wonderful start, and I think now they're working more toward making it for older child, for toddlers, and preschoolers now. I think they're working on this model, and also they're trying to get as early as possible. That's a wonderful preventive model for the children who have more, like needed more trauma-related work, and parents who need additional work. Child-parent psychotherapy is another model, 0 to 6, and some areas I know that people start to run it with young school-age children. I do find that we are not as good in terms of model for the school-age children, because we have a wonderful trauma-related model, TFCBT, trauma-focused cognitive behavior intervention. That's great, but on building relationship, we need to think and be creative, because this piece for some kids who just placed also need to be. There are some great programs, like more trying to get multiple levels approach for adopted kids, but in terms of intervention, we kind of don't have one to address a relationship building, and we that's kind of the interest we do have to develop consultation, that we have more and more school-age children placed, because we know that unfortunately it's not only infants and not only young children, but we need to be sure that relationships successfully built over the whole spectrum of ages. But that would be kind of the models that we are using.
Thanks so much. Those are really helpful resources. Thanks so much for your time. It was really lovely to speak with you about the chapter. Thanks again for contributing, and also for talking to me a bit about your work.
Thank you.
Thanks for joining us at Adoption Roundtable. Please subscribe wherever you access your podcasts. We love to hear from you and have conversations about your reactions, questions, and experiences. We'd especially appreciate feedback if you have topics or questions that we could address in future episodes. You can find me on Facebook at helder.emily and at my website, emilyhelder.com. There you can sign up for my newsletter for the latest on adoption research and practice. Thanks for joining us.